Hi, I'm Dr. Kristina Dervaitis. Welcome back to my channel dedicated to education around the topic of long-acting reversible contraception, all things to do with IUDs as well. So today I am re-recording or updating a video that I did a number of years ago about IUD insertion and basically a step-by-step guide to insertion. I wanted to re-record this video because I just wanted to clarify a few things, some points that had been brought up by viewers in the past. Also, there have been some new developments in Canada in terms of options that we have for patients for pain relief. So I wanted to address that as well. So the first part of this video will be sort of a step-by-step explanation of the actual IUD insertion process itself. And then the second part of this video, I'm going to address the issue of pain and IUD insertion, what to expect. Is this going to hurt? How much is this going to hurt? I'm going to try and answer those questions and delve into the issue of pain, what to expect, and options for pain relief at IUD insertion. So just to start off, I want to address the fact that many of the patients that are coming to see me for an IUD insertion, it may be their very first gynecologic exam, that is absolutely okay, and I just will walk patients through each step and go very slowly and explain what I'm doing. It's not necessary for you to have seen a gynecologist before to have an IUD inserted. It's not even necessary for you to have been sexually active before to have an IUD inserted. A good percentage of my patients are patients who are having IUDs inserted either before they're about to become sexually active or having IUD insertions for reasons related to their menstrual cycles and getting help with menstrual bleeding from the progesterone-containing IUDs. So it is not a prerequisite for you to have been sexually active in order to have an IUD insertion. So first we would start by getting the patient positioned. I usually use what's called stirrups or the foot holders, and we have the patient sort of wiggle down so that one heel is in each of the stirrups, and we get you shimmied into position so that your bum is sort of at the right distance for me to do what I need to do. Part one, I would be just doing what's called a bimanual exam to examine the patient to assess the size of the uterus, the position of the uterus, whether or not the ovaries feel normal or are there any abnormalities there. So to do that, it's really just one or two fingers placed vaginally, and I've got this little uterine model. It's not the greatest, but if this was a uterus this way and this is sort of a side view, it's basically me just putting fingers into the vagina so that I can feel the cervix, and then with my abdominal hand I'm feeling and pushing down and feeling the top of the uterus. So by that, I basically have the uterus between my two hands abdominally, and with my fingers vaginally feeling the cervix. And then to each side, we sort of maneuver to feel the ovaries, and that's what's involved with the bimanual exam. So that's step one. So step two is speculum insertion. And for those of you who aren't familiar with the speculum, sometimes it gets called the clamp or the duck bill or what have you. It can be an intimidating instrument to look at when you just see it like this. Oh my goodness. But keep in mind that this portion that goes vaginally is very, very narrow here. And we just go very slowly. And this is basically inserted. And so the rest of this is a handle and does not go anywhere near the patient. So, and this is just basically inserted into the vagina so that we can open it. And sorry, I'm not doing a very good job of showing you this, but you can see the cervix, if you will. So that's so that I can actually visualize the cervix head on. So, and sorry, I'm not great at like graphic design and all of that fancy stuff. There are probably better IUD insertion videos out there with all the fancy graphics that will do a better job of explaining this, but this is my attempt. So we continue. And then just speaking of the speculum exam, I just want to bring to your attention that there are different sizes of speculums, and your doctor or healthcare provider will assess your anatomy at the time. It's not a one size fits all situation. So if if someone has a more narrow vaginal opening, then we might use a more narrow speculum, or sometimes even the very smallest of speculum. So we have sort of a different assortment of sizes and shapes that we can choose from to fit the patient's anatomy. So keep that in mind. Now, once the speculum is inserted, for the actual IUD insertion, there are 2 mandatory steps and then a third step that I'm going to talk about. So what happens is that basically this narrow little tube has to actually go into, again, sorry for not having a better setup to show this, but so this basically this narrow little tube needs to go into the uterus in order to insert the IUD, and I'll show you in a minute. Before we can put the tube into the uterus, we have to measure the uterus. So that's called sounding the uterus. So usually there's a cramp and usually the part that's most sensitive is when we measure the uterus and when the top of the uterus is touched that way. That can be really crampy for patients. So I warn patients, okay, here's cramp 1. And now cramp 2 is the IUD being inserted. And then I'll just show you here. It basically, we depress this lever and it sort of releases the IUD into the uterus. And then when it's pulled out, that way it stays in place, and then we just cut the strings here. Now, in order to do that insertion, the cervical canal rather needs to be sort of at a straight positioning without curves to it. So occasionally, I would say about half of the time in my practice, occasionally we need to manipulate the cervix in order to straighten the canal. Now, again, not every patient not every patient will require this next step, and that's part of why I didn't include it in my original video and people got sort of upset at me. I wasn't trying to mislead anyone. It's just that I don't always do this next step. If I have a canal that is straight, then I don't need to straighten it. It's already straight in front of me. So I'd say in about half of my patients, this next step isn't necessary. But in the other half of patients that we may need to apply what is called the tenaculum to the cervix, and there's been a lot on social media recently of the dreaded tenaculum and showing the teeth of the tenaculum and showing it biting down into the cervix, and oh my gosh, what are these gynecologists doing? But a couple of things on tenaculum placement. It's important to note that the nerve supply to the cervix is very different, such that it experiences pain in a different way than if you were clamping this onto your skin, for example. So when I place a tenaculum, first of all, we're not always, having to squeeze huge amounts of tissue into the grips of the tenaculum. Sometimes we're just gently holding it and not even completely closing the tenaculum. That's one point. The second point is that a lot of us will use distraction techniques like having the patient to cough at the same time as the application. That can help with the discomfort. And the third point I would bring up is that even though this seems really dramatic, I have to say that during IUD insertion, probably the part of the experience that makes patients the most uncomfortable, where I get the patient yelping and really not happy with me for a moment, is actually the top of the uterus being touched. And when that little spot where I've measured the uterus, and when my uterine sound actually touches the top of the uterus, I find that with my patients that has been more of the discomfort, not really the tenaculum application so much. So, and then we're going to talk about pain relief with respect to all of this at the end of the video, but keep in mind that everyone's anatomy is different. So some uteruses are really sensitive at the top when they're touched. Others may not have discomfort there, and but we're gonna talk about that in part 2. So just getting back to the steps. So step 1 is patient positioning. Step 2 is the internal bimanual exam to feel the uterus and ovaries. Step 3 is insertion of the speculum. And then sometimes step 4 that step may or may not be necessary. And then there is the final 2 steps, which is measurement of the uterus, 1 cramp, and then another cramp for the IUD to be inserted. In a straightforward IUD insertion, particularly if I don't actually even need to apply tenaculum, the time between cramp 1 and cramp 2 is often 15 seconds, and I count the patient down through that. So I've been chatting with you for quite some time now. Like, I would have probably been able to insert 3 IUDs in the time that I've been speaking to you now. Like, really, the actual steps happen very, very quickly, and usually the whole thing is done in a matter of 2 to 5 minutes kind of thing. So, and my previous catchphrase on the channel was 5 minutes, 5 years. Now, given recent changes to duration of use for Mirena and also guidelines around the copper IUD, it could be 5 minutes for more than 5 years of worry-free contraception. So afterwards, in my practice, I also will do a bedside ultrasound. Now, this is an optional step. Not every office is set up to have ultrasound access, nor is it absolutely necessary. I find that because the technology is advanced, that I can have an ultrasound that basically fits in my pocket, and it sends an image to my phone screen. So I like to have that extra reassurance and checking placement immediately after I've done the IUD insertion. So that's an optional additional step that may or may not take place in the office. So that's a little bit about the actual steps for insertion. And now I'm going to talk a little bit about pain at IUD insertion and what to expect and what we can do to help with pain. How painful is this going to be? Is this going to hurt? What should you expect? So there's no simple answer to this because everyone's anatomy is different and every patient is different. It can depend on a number of different factors, depending on how open or not open the cervix is, the angle of the cervix, whether the patient has had kids before. Various things can influence IUD insertion and the degree of discomfort. What I want to make clear is that I'm not here to try and minimize the pain that some women feel at IUD insertion or minimize their experience. I'm not here to deny the fact that some patients have a very painful IUD insertion experience, but I will say that that is the minority of the patients. In previous videos, when I sort of discussed what to expect and emphasize the fact that, you know, it's intense pain for some patients, but it's over with really quickly, and 5 minutes, 5 years of worry-free contraception. None of that was meant to try and deny the fact that there are outliers and there are some patients that do have a really painful IUD insertion experience. I was trying to, encourage patients, trying to reassure them, and also trying to help them keep things in perspective in terms of, we're talking about a 5-minute procedure that's really uncomfortable, but for long-term gain. It was not meant to try and deny the fact that some women have a very exceptionally painful IUD insertion experience. The problem is, well, there are several problems, but the problem is that it is not really easy to identify who is going to have a more painful IUD insertion experience. There's not one checklist or one list of criteria that tells me who is going to be the one that has that really sensitive top of the uterus, that when I touch that with the sound or with the insertion device, that they're going to jump off the table. There's just not really a way for me to screen for that. That's one problem. The second problem has been that up until recently, we haven't really had a lot of great options in the office for pain relief. And I'll explain. One issue is that we've talked about, the media has talked a lot about IV sedation or even general anesthesia for IUD insertion. IV sedation would be very helpful in some situations, but in other situations may be completely unnecessary and subject the patient to a medication that they otherwise wouldn't need to take for the procedure. It would require them to have a driver to the appointment. It might require that it's done in a hospital setting, which would limit access, and there might be longer wait times. Especially with general anesthetics, there are risks associated with that to consider. So the idea of subjecting the entire population to something like IV sedation or general anesthesia, whereas only a small percentage would actually, in hindsight, say that that would have been beneficial, seems, like it's unnecessarily restricting access for a great number of patients. There have been things that have been looked at. They've looked at doing sprays to the cervix, so like lidocaine sprays. They've looked at different topical anesthetics to the cervix. They've looked at injecting the cervix with freezing, a paracervical block it's called. Up until recently, there has not been any great evidence to support those measures to say that, yes, if we do this, for sure the patient's going to have an improved IUD insertion experience. The studies have been small in number. Particularly, there's been conflicting evidence about the paracervical block. I've seen a lot on TikTok or on social media, on Instagram, doctors saying, God, doctors, why aren't they offering the freezing? Why isn't your doctor giving you freezing for your IUD insertion? Well, what they're forgetting to mention on their post is the fact that that freezing often is going into the cervix with a needle. And that freezing in some studies has been shown to be beneficial, and in other studies shown to not considerably improve the IUD insertion experience. So usually when I talk to my patients about putting a needle into their cervix, they tell me no thank you, and particularly when I tell them that it may or may not help. Some studies actually showed that the needle into the cervix was better for helping with pain with tenaculum application, which I sometimes do and sometimes don't, depending on the patient's anatomy. For me, the idea of putting a needle into the cervix to decrease the pain from a pinch to the cervix, I'm still waiting for more convincing evidence. There are a number of trials that are ongoing, particularly one here in Canada that I'm eager to see the results from. We do have a couple of options that I want to talk about, that I do talk to my patients about. So option one, and something that I generally recommend to every patient, is naproxen. So this is the active ingredient in the over-the-counter pain medication Aleve. So naproxen at a dose of 500 milligrams, or if you take 2 Aleves over the counter, it's 440 milligrams, so it's close to that. So if you take 2 Aleves 1 hour before the IUD insertion experience, that can help with the cramping during the insertion and also subsequent cramping. In Canada, we have a new option available beyond just taking naproxen prior to the procedure. There is the option of something called Penthrox. It's been available in Australia for more than 25 years. There was some question of it being originally used in the US, and I think currently it's not available. There were concerns around liver and kidney toxicity, but I will tell you that those concerns are for far greater dosages than what is used typically for an IUD insertion. So I'll explain what Penthrox is. It's an inhaler. It's methoxyflurane. It is basically a liquid that gets poured into this little inhaler, and it's sort of like a mini laughing gas, if you will. It takes you to la la land. It's very fast acting, and then the recovery is also fairly quick from it. But it basically makes you very relaxed. There's an euphoria associated with it, like, for lack of a better term, a high sensation, and it can help a lot with anxiety. It does have some pain relief function. It doesn't completely eliminate the pain, but it can make the entire experience much more tolerable for patients. And what I love about this is that it doesn't involve a needle to the cervix. First of all, some patients are so anxious that it's hard to even do the speculum exam, which you need to do a speculum exam before you start putting freezing into the cervix, for example. But with this, because it's, an inhalation format, then it's very minimally invasive. It does involve an intravenous, and there are very few contraindications. So currently in Canada, this is available. It costs about $65 to $80 depending on the pharmacy that you go to. I'm filming this right now in June of 2024. That may or may not change in the future. Most drug plans are not covering it. OHIP Plus is not covering it. So national drug plans are not covering it currently. I'm not sure if that will change in the future. 80% of patients would say that they didn't really actually think that they needed something like this, and it was not necessary. But I do talk about it with all of my patients. Some patients say, you know what, I'm just gonna go and see how it goes. It's 5 minutes. I think I can get through it. One thing I emphasize to all of my patients is that if at any point in time things are too intense and you need me to stop or back off, you just say the word. You're in charge here. So if someone decides not to go ahead with something like Penthrox and wants to just give it a go and see how they do on their own, if it becomes way too painful and we need to stop and back off and reschedule and consider something like Penthrox, that's absolutely an option kind of thing. So that's just something that's newly available in Canada in the last year or so, and new to my practice, and I've been using it with a lot of patients now. So I just wanted to re-record this video to give sort of an update on pain relief options. Now, in terms of what to expect for pain after an IUD insertion, the most intense pain is usually during the first 5 to 10 minutes, and then things generally die down to more like period cramps. For some patients, the cramps might last hours. For some patients, the cramps might last a few days. Rarely would it be lasting for weeks and weeks. But I usually advise that patients can continue to take a non-steroidal anti-inflammatory like Aleve or extra strength Advil, for example. And then Tylenol works differently, so you can use Tylenol in addition to the anti-inflammatory class of drugs, but the anti-inflammatories do tend to work best, so I usually advise patients to start there. So that was just a little bit about IUD insertion, and to try and give a bit of a more detailed perspective of what actually happens at an IUD insertion, and to talk a little bit about pain relief options. Remember, and I'm going to say this again and again with no attempt to minimize the IUD insertion experience, but I will say that the vast majority of patients find the pain manageable. It's unpleasant, but it's very, very quick. And many patients find that it's well worth it to go through that experience for 5, 8, 10 years of worry-free contraception, depending on the IUD. But that said, there are patients that find the experience much more uncomfortable than others. And so for those patients, I'm happy that at least here in Canada, we have some simple options for pain relief in the office that we can explore with patients. So that's all for now. If anyone has specific questions, of course, please drop them in the comments, and I will continue to post new videos as things change in the world of long-acting reversible contraception. I'll keep you guys posted. Okay, take care.